Hi, my name is Aisha Khan. I'm an assistant clinical professor at the Stanford University School of Medicine. Today we're going to be talking about preparing for an emergency, and we'll be going through a case presentation with my good friend, Dr. Matthew Strelo, who is an associate clinical professor also at the Stanford University School of Medicine. Thanks for joining us, Matt.
Thanks for having me, Dr. Khan.
So, what I wanted to talk about is every once in a while in our hospital, we get a ring down where they tell us that there's multiple patients coming in at the same time. Sometimes this is because of a mass casualty incident, and sometimes it's just because there's multiple ring downs, multiple patients that have to come in. How would you go about preparing to see all of these patients?
Well, when we get either an MCI, what we call a mass casualty incident, or we just get an influx of a lot of ring downs coming at once, and so we feel like that's kind of stretching our capacity, I always like to kind of divide the things that I want to think about into some categories. One is I think about the staff that I'm going to need. So do I have the doctors, the nurses, the ancillary staff? You know, these are things like radiology techs and other hands on board. So do I have enough staff? That's one. Secondly, do I have the space? So do I have enough rooms and beds for these patients, right? Because you're going to have, your ED is always going to have patients in it, and now you're bringing in a big influx of another group of patients, and you have to identify where that space is going to be. And sometimes that means putting patients in the hall. Sometimes that means, you know, if it's a ring down with a lot of cases, that might mean even expanding your emergency department to an area that's outside of your typical operational area.
Wow.
So staff space, and then I think about equipment. So do I have the equipment? And with equipment, I often put things like diagnostic, you know, testing supplies, things like that I'm going to need. So both for the care and the diagnosis of patients. And then I also like to think about, are my staff prepared? So do I have my, you know, my personal protective equipment? Do I have enough gowns and gloves and other things like that? You know, shielding for radiology, oftentimes in traumas, we think about that as well. So do I have enough lead aprons and all that equipment that I need to keep my staff safe as well? What about you? Is there anything else that you think about when you have these ring downs? Because I know you handle them as well.
Yeah, well, it sounds like all of these things kind of fit into what I would think about as an environment that we're creating to optimize the care for our patients. Sometimes when I'm preparing to see multiple patients at once, I start to think about the order in which I'll see them too. Do you guys do anything like that, or do you just see patients first come, first serve?
No, we definitely put our patients in a specific order. And when we get a ring down, we typically get information about what level the pre-hospital care providers think those patients should be in. So it's a assessment by them based on both what they're finding on that particular patient and also what the possible mechanism of injury, if it's a trauma or other things like that. And that ring down then sorts the patients. And they kind of tell us, is it a code 3 or a code 2? And what that kind of does is tell us how sick they think the patient is or how emergent they think the patient is. And that helps us kind of do an initial ordering of how we're going to manage the patients, where we're going to put them, what staff we're going to assign, all of that kind of stuff. Now, it's not perfect, so we always have to, you know, be very vigilant and aware that these things is in change. But when we're setting up our environment, we're also going to think about which patients we're going to see first, because you never have enough staff almost, right? You never have enough doctors, you never have enough nurses, so you have to prioritize a little bit.
Okay, that sounds great. That sounds like a good way to do things. Let's take a look at how things are done at this one hospital.
12-year-old, minor burns and radial deformity. GCS is 15. Vitals are good.
33, IV morphine, X-ray.
Let's see her as soon as we can, okay?
Annie Dixon, 37, abdominal pain and headache.
So it looked like that doctor rushed out to meet all of those patients that were coming into her hospital, and she was quickly sorting through them. I saw in a lecture that that's called triage, and I was wondering if you could tell me a little bit more about what triage is.
Yeah, was it a lecture you gave, by the way? Yeah.
I think so.
So triage, the way I like to think about triage is that triage is a kind of a rapid sorting of the patients into priority of who I think needs to be seen first based on how emergent their possible problem is. So it's, you know, I want to see kind of the worst first, but it's also a time-dependent issue, right? Another way I think about triage is I spend all my life triaging. Like I'm driving into work and I'm trying to think, I'm triaging basically what I'm going to do for my day, even if I'm sitting in my office, because you're thinking, what are the things that need to be done immediately because there's a deadline versus the things that may be important but actually can wait for a while. So triage is the same thing, but triage is applying that concept of time-dependent ordering of the patients and sorting of the patients in the emergency or even in the non-emergency setting, meaning when you're in the hospital or something like that, this can happen, right? You receive a phone call.
Sure. So is prioritizing them, like, do you need to diagnose them first in order to do that?
No, because diagnosis takes time, right? And so if you spent a long time with each patient determining their diagnosis, you would end up spending a lot of time on a patient who may have a problem that's not emergent, while somebody else is sitting there with an emergent problem that no one has even seen yet. And by the time you get to them, something bad may have happened.
That's true. I sometimes think about when there's a long line outside, what if the sickest person is at the end of the line and not in the beginning?
Yes.
So you have to move through those patients really quickly.
Yeah, and I think I've seen that both, in the international setting and sometimes in our own emergency department, unfortunately, with the waiting rooms. You walk in and you see the waiting room is now out into the hallway and the things have spread around. And you're hoping that the person at the end of that line is not the one that's critically ill and needs an emergent intervention.
That's right.
Let's see as soon as we can, okay?
Eddie Dixon, 37, complaining of abdominal pain and headache. Tachyon hypertensive, SATs 92. Trauma 1's open. I'm Dr. Banfield.
My kids, they're doing okay, Mrs. D. They're just more scared than anything.
So I just heard that doctor say, take this patient to Trauma 1. What is Trauma 1?
Trauma 1, well, I don't work at that hospital, but in general, when we have a potentially critically ill patient, we want to get them into our room that's most prepared. We often call that Resuscitation Room, where if someone's critically ill, we can kind of resuscitate them, bring them up, and provide the immediate care that they need.
Okay, because that patient didn't even have a trauma, but she was just referring to the room as Trauma 1. She was talking about her resuscitation room. Okay, it was a critically ill patient.
Right, and a lot of times we use the same resuscitation rooms for our trauma patients and our critically ill medical patients as well.
I see.
Sometimes we don't, sometimes we do, but the equipment you need in most of the cases is fairly similar.
Okay, so it's an area to see critically ill patients, whether they're trauma or medical.
Yes.
Okay, and what type of stuff do you have in this room?
Staff, doctors,
Sure.
nurses, that kind of stuff. But you also want to have some other things to help you deal with A, B, C, D problems, right?
Got it.
So whether it's a trauma or a medical patient, you're going to want to have your airway equipment.
Right.
Right? So you're going to want to have the equipment for bag, valve, mask, ventilation. You're going to want to have the equipment for endotracheal intubation and airway management. You're going to want to have equipment to support breathing. A lot of times we'll put ventilators in there as well, like smaller or portable ventilators in the emergency department. In the ICU, they'll have bigger ventilators. And then your C, right, your circulation. So you're going to want to have a lot of different ways of getting access in the patient, or intravenous, intraosseous access, along with other ways to help with C. So a level 1 transfuser, which is something which is infuse the fluids or the blood very quickly, pressure bags, and then other things to stabilize C. So if it's a trauma room, you're going to put in other things like a pelvic binder or a
surgical tray, maybe?
A surgical tray to do things like either a needle or a tube thoracostomy or things like that. So you're going to have all the things you need to manage your A, B, C, D problems in there, because the idea is those problems need to be dealt with right away. And you don't want to be saying, okay, can you run downstairs to Central Supply and grab me an endotracheal tube? That'll be great. And then you're just sitting there waiting it out. So the resuscitation room is where you're going to put the critically ill patient because you have the critical supplies you need.
So I know, like, in early goal-directed therapy, for example, antibiotics are really critical. So should those be in the resuscitation room as well?
Well, that's a good question. I think that what we have done, or what most places try to do, is have critical medications in there. And that you're going to need for the A, B, C, D problems. Antibiotics is a little bit outside of that, but as we've learned about antibiotics being really important early, we have put some of those other medications available in those rooms so that we don't have to go to pharmacy or things like that.
What about like ACE wrap and, like, because I was thinking, and it just seems like in an emergency room, you need everything right away, right?
Right.
Everything is so time critical. But then if you have so many things, how are you going to organize it so that you can get the most important things you need in the first few minutes?
Well, I always ask myself, have I ever saved a patient's life with an ACE wrap? And unfortunately, the answer is no, because if I did, I would feel pretty good about myself.
Right.
But I think if you say to yourself, am I going to be able to save a patient's life or limb with this piece of equipment or this medication or something like that quickly? And the answer is no. You may not want it in your resuscitation room because we have a space problem, as almost every emergency department, every hospital, honestly, around the world has a space problem where the room is never big enough for all the people and stuff you want to put in there.
Right. So maybe a good way to think about it would be, what will I need in the first 10 minutes, or what will I need in the first 20 minutes, not in the first hour or 2 hours.
I think that's a very good way to think about it.
Yeah, because really, as long as it's somewhere in the ER, we'll have time to go and get it otherwise, right?
Right, or even in the hospital, right? If it's something that you need in an hour or two, that's something you're going to be able to go somewhere else in the hospital and pick up.
Right.
But not the case in things that are A, B, C, D problems or the first 10 or 20 minutes.
I think it would make organization so difficult if we had just a whole bunch of stuff.
Well, you can't go, there's a fine line between having too much stuff and then sometimes not enough stuff. I think we've all been in that experience where we're sitting in a room and you're like, oh, there's no crash cart in here. And crash cart's where we store all those critical, those supplies organized for like airway stuff and things like that. And so you really have to think about this in advance. This all goes into your preparation issue, right?
Right.
So this is not something you prepare once you get the ring down. This is something you prepare as a group, whether you're a ICU group or whether you're a group otherwise in the hospital. I would say even in a clinic that sees a lot of patients, you should have a plan for if a patient gets very sick on you or presents very sick to you on what you're going to do. And that plan must include setting up a space with the appropriate supplies.
Sounds great.
It's Norman, the Good Samaritan of the neighborhood.
They're in 3A and I'm in 4B.
Heard the explosion, ran in to get the kids out.
Yeah, let alone she likes to cook for me. She's a serious.
Don't forget, you're over the crush injury to the leg.
All right, curtain 3, get going on. Rena, honey.
They're in good hands, Mrs. D.
Castro picked up 5 more beds.
Good. This is Norman. He needs access fluids and pain meds.
No, take Mrs. Dixon. She's much sicker than me.
Yeah?
No, I got her. You help Gates. Maybe you can benefit from having an experienced resident in the room. Just in case.
Just in case what? Got your back, Johnny.
Wow, she did an amazing job sorting through those patients so quickly. One thing I noticed was that there was like 3 doctors out on this ambulance bay. Sometimes I don't even have 3 doctors in my emergency department.
You mean most of the time?
Most of the time. So is it really a doctor that should be doing the triage?
Well, the doctors can do triage. It's definitely something that I think should be within our knowledge base and our skill set. But the majority of time, you don't have doctors doing the triage, right? Most of the time, it's been shown that you can do effective, accurate triage with other healthcare providers as well. Nurses, and sometimes other nurse assistants or other staff as well. So the vast majority of the time, nurses do triage, though. We don't have 3 doctors run out onto the ambulance bay unless we really have a true mass casualty and we've brought in extra staff because like you said, even in our, even when we have a lot of doctors running around the emergency department, people are busy. They're doing things and running out on the ambulance bay sometimes only delays things.
Sure.
Rather than actually improves them.
Right. Yeah, it seems like any person who's trained in triage should be able to do it.
Yeah.
Right?
I mean, I think there's a lot of ways of doing triage effectively without doing needing an advanced degree in medicine or healthcare or something like that.
So that brings me to my next question. How is it that we should triage if you don't have the experience to recognize a really sick patient when you see them just by looking at them?
Well, even if you do have some experience, I actually think that using what we have, our triage systems, is a good way to go about doing triage. Because it's easy because you're only collecting a small amount of information, whether you're experienced or not, to kind of misinterpret things when you're just getting that brief glimpse. You saw how quickly that doctor was seeing the patients. And
Right.
did she really have a good handle on how sick those patients were?
I know, she was even yelling out orders.
I know.
I was wondering if she was
Maybe-
doing that.
Maybe, maybe not. But triage systems are systems that are designed and for the most part studied and validated to look at a large array of patients. They're presenting complaints, symptoms, and some very easy to obtain signs like vital signs or something like that. And then sort them into what patients most likely have an emergent condition versus those that have a less emergent condition. And I like to distinguish an emergent condition versus a life-threatening condition.
Okay.
Patient comes into you and they've got severe lung cancer that's spread everywhere and they're just in pain, right? Say they're having a lot more pain in their back. That patient, unlikely to have an emergent condition where if you don't do something immediately, that patient's going to have a bad outcome in the short term. But as far as the severity of that patient's illness, that patient has a life-threatening illness, is likely going to die from that disease. So it's not a matter necessarily of determining who's the sickest,
Right.
but it's a matter of who's the most time-dependent, okay, and the sickest kind of combined,
Okay.
right? And so that's what these triage systems have focused on. There is a lot of different triage systems. In the United States, we have gone over to primarily using something called the Emergency Severity Index, or ESI.
Okay.
And so the vast majority of at least larger emergency departments in the United States now are using the ESI, or Emergency Severity Index. And that's a 5-level triage system. And it uses some brief questions, vital signs, to then and then how many resources are going to be needed to categorize your patients into 5 different levels, with 1 being, hey, this patient's coding or about to code right now and needs an emergent resuscitation, all the way down to 5, which is the patient is basically non-urgent. Now there's other systems as well used around the world, and the systems have, kind of each place has their own system to some degree.
Sure.
The Canadians have a system that's very well validated. There's an Australian triage system that has been well validated as well. One in the UK. There are some systems that are designed for lower resource settings as well. And those include things like the ETOT, which is from the WHO, the 1-2 triage, which was designed by Stanford actually, along with the Cambodian group from Cambodia. And so the type of system you use is probably less important than using a system at all.
Right. That's really interesting. So I heard you say that ESI, for example, divides patients into 5 different levels. And, I think some of them use colors, like a red patient or an orange patient. One thing I was thinking is that probably makes it really easy to communicate to somebody how sick a patient is.
Right.
In the clip we saw, the paramedic was giving the physician an entire rundown of what was going on with the patient. And if you think about it, that was taking probably most of the time, but that it took for the physician to figure out where to put the patient and what to do. But if she had just come and said, oh, this is a red patient, the doctor would have known right away, this one needs to go to resuscitation.
Exactly. So no, that's perfect. That's exactly what you're trying to do, is consolidate communication and standardize it to some effect, right? So I know that if the patient is red or an ESI 1, I know what that means, versus you might think, well, this patient probably needs a resuscitation versus, maybe not. And we might have different ideas in our mind of what's, the line for me using the term critical or me using the term emergent. But when I use a triage system, we've standardized all that language and all that goes into it. And so we can communicate quickly and we can communicate correctly. That's
great. Thank you so much for joining us and talking about triage. I just learned a lot.
And,
so did I. And this was a really interesting case.
Well, thanks for having me.
Thank you.